Hello, thank you for joining us. We'll get started in just a few minutes. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The planning committee members and speaker have disclosed no relevant financial relationships. To receive a contact hour for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to our presenter. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We'd like to thank our speaker for sharing her expertise with us today. Our speaker today is Joanne Porter. Joanne has worked at the Federation University Gippsland campus since 2002 and is currently the Director of Collaborative Evaluation and Research Group. Joanne has an extensive research history with multiple publications in peer-reviewed journals and competitive grants. She continues to lead clinical and community-based research projects. Joanne is an emergency nurse with an interest in family presence during resuscitation, with a number of publications in this field. We're so thankful to have you. Welcome, and we'll turn it over to you.
Thank you. I'm really excited to be here today. It's been a while since I've been able to present on this topic. I'm just going to share my screen so everyone can see it. I'm hoping that you can see the PowerPoint.
Yes, looks lovely.
Great. So hello, as I was introduced, Jo Porter is my name, and I'm here all the way in Gippsland in Victoria, Australia, beaming to all over the world. And I see in the chat room we've got people coming in from lots of from every corner of the world. So I'm really excited to be presenting here today. Now, you might say, gee, family presence during resuscitation is a bit of an old topic. We've sort of done that. It's something that's very close to my heart and something I've done a lot of research in. But the global pandemic has really put us back to really the beginning of practice. And so I felt that it was timely to revisit this topic and to really think about our practice in resuscitations, whether or not it's in the emergency department to intensive care or onto the wards, and how we engage family in this practice. In order to get the best out of this session today, and I must admit, I mean, I know that it's me talking and I'm going to try and be as animated as possible, but I really think to get the best out of this session, I suggest that you get a pen and a piece of paper. There's a couple of activities that I'm going to give you a little bit of time to kind of write your thoughts down as we go through. So I'd like you to be as engaged in the material as possible. We're going to do a little bit of an introduction session and some activities and a little bit of theory. And then I've got some videos to watch as well. And then that should provoke some thought about where, you know, how you practice around family presence during resuscitation. The ER DRIP is an education package that I developed as part of my PhD study. And it's an acronym to remind us of what to say and how to say it when you're engaging with family during resuscitation. So I'd just like to start the session by acknowledging the traditional owners and custodians on the lands on which we all meet across the world. And I'd like to pay my respects to elders past, present and emerging, and anyone present in today's meeting. And I'd like to further acknowledge our commitment to working respectively to honour their ongoing cultural, spiritual connections to this and connections to the countries in which we are located. I put the Australia map up just so that to remind you and to showcase where I'm located. The bottom state, Victoria, just close to Tasmania, and I'm right on that little slight bit down here. That's where I'm sitting today, so and beaming. And it's 9 o'clock in the morning for me, but I'm sure it's a number of different hours across the world as you're listening in. Going from screen to screen here. Oh, sorry, I just need to get this up. Okay. I wanted to read something to you to start with, just to start thinking about how your thoughts and your clinical practice around having family during one of the hardest times when we're clinically nursing, which is during resuscitation. And I became interested in this topic because of a number of different incidences that happened to me. I remember being in the emergency department on this particular day, and we had one of those horrible dread feelings as the nurse brings in a mother from the waiting room with a limp child in her arms, and they're brought into the emergency department, and we lay them into children's resuscitation area, and we start to work on this child. And it's this frenzy of activity as we're taking vital signs and checking their airway. And it seems like it's a cast of 1,000 as everybody comes in. The consultants come in, the emergency clinicians, the anaesthetist is called down. You've got pediatricians, nurses, doctors. There's so many people in this around this small child. And I was busy doing the hands-on activities of resuscitation. We had a very experienced nurse at the time who was doing the airway, and she looked up at one point, and she started to sort of see that it really was so many people in this resuscitation room. And she just pointed and said, right, you and you out, go back to the cubicle, start looking after the other patients. Medical students, no, not appropriate, out you go. We're not having you in here, it's too busy. And then she said, you, right, well, who are you? And without realizing, the parents had just been left standing on the side of this big resuscitation cubicle. And every time somebody else came in, they just backed up further and further into the wall of the resus. Not one person was talking to them. The look of dread on their faces as though it was being ignored as their child is being resuscitated. And the image of these parents has always stuck with me, that somehow in the busyness of doing the resuscitation, we're just missing that one element, that we're just not having somebody designated to care for the parents. And that's a really one of those pivotal moments in your clinical careers where you say, I'm going to change my practice and I'm going to do better at that. I'd like to read a quote to you that again hits home about the significance that we can make in somebody's life. And this quote was written by a nurse whose husband was a police officer who'd been brought into the emergency department. And she wrote this later to the staff. "I don't know your name, but I will never forget you. You played a part in the most important event in my life, but you didn't share in that painful experience with me. You just happened to be present. I want to leave you with this thought. Death is painful for all families. When it's expected, family members usually have time to say goodbye. But when death is unexpected, there's no time for those last intimate moments. I had one opportunity, one moment in time to sit by a stretcher, hold a warm hand and say goodbye. You stole my moment." For me, this quote and remembering back to watching the parents in the resuscitation room really hit home for me as a practitioner, really thinking about how can I make that difference to the lives of the family as we're caring for their family member who is being resuscitated. There's a famous quote by a physician, and I love this quote. And he said, "Having family present, it's not a spectator sport. And if it was ever made to be made mandatory in our practice, I will give up practicing." He was actually talking about birth. He was talking about having husbands and family members present during the birthing experience. It was quoted back in about 1965. And I just think it just hits home. We've actually had these conversations at the beginnings of life, and now we wouldn't think twice about having not just the husband and the extended family come in the birthing experience. And yet at the other end of life, and as people are passing and dying, it's often not the common practice. Now, today's presentation it'll be hard to listen to, and I'm sure it'll provoke a lot of thoughts and probably memories of times where you've had dealings with families, and also where perhaps over the last 2 years in particular with COVID, it's been difficult. And I do recognise that. And hopefully, though, we can talk about the experiences in a way that just provokes you thinking about the practice moving forward. So we will cover the things we know about this topic, and then we'll talk a little bit about the impact that COVID's had on this practice in general. And then hopefully come out the other side thinking about what the future looks like for having family being involved at a time when the patient may or may not actually die. So for the first activity, what I'd really encourage you to do is have a bit of a think about what are the benefits, what are the barriers, and what are the enablers in which would help to facilitate or to implement having family present during a resuscitation. You might work across multiple different clinical areas. This isn't just unique to the resuscitation areas in an emergency department. It's equally as relevant in intensive care and high acuity as it is on the wards. Thinking about how we practice. So what are the benefits? What benefits do you think there are for you as a practitioner, for the family, and for the patient? What are the things that are the barriers to being able to implement that? And I want you to think more than just those COVID restrictions as well. And what needs to happen in order to actually make this common practice? The reason and the thing that drives me about this topic is that there's no consistency in the practice of family presence. It's often dependent on who the team leader is, who the doctor is, or who's on the shift, who's comfortable with having family there. So it's dependent, but it needs to be consistent practice. And talking about this topic, it's actually really important to not just clinicians, but to actually every person. One of the things I really like to do is is chat to older people. And when you retire, often in Australia in particular, we call them the grey nomads, as they get in their caravans and travel around Australia. But to think that it doesn't matter where you are around Australia or around the country or around the world, that if your partner is seriously ill and needs resuscitation, that you will not be allowed to go in. It should be common practice, and it's not. So I'm just going to give you a moment to think about those three things. So I wondered, when you thought about the benefits of having family there, some of the common things that have come up in the literature, in the research around this topic, is that it really does help families with their grieving process. It helps them to understand the dire nature or the complexity of the medical condition that the person being resuscitated has. So it really helps take those first steps. You often hear family members start talking about them in the past tense rather than the present tense. And you can see them make a transition as they actually realize that perhaps their loved one is actually going to pass. Really importantly, having family there, they know that everything possible was done. They've seen how hard you work. They've seen all the things that you tried. They've seen the team really put in as much as time and effort as much as they possibly could. And there's such gratitude. And knowing that everything possible was done helps them to also come to grips with the fact that nothing more could be done. It facilitates that closure and healing process. And in particular, it reminds staff of the patient's place in the family unit. It reminds us that this is not just a body and not just a patient, but an active member of a family unit. If it's a woman, it might be a daughter, a mother, a sister, an aunt. It's their part in the family and their connection with those family members. It strengthens the bond between the staff, the family, and the patient by actually hearing their stories and understanding where they've come from and what's happened to them in the past, or what they do for a living even. And it absolutely ensures staff behave professionally at all times. And I know I shouldn't even have to say that, but we do operate differently knowing that the family are present. It keeps it very clinical, but it also keeps us very respectful in our language towards one another, and it does change the atmosphere for the benefit. Some of the barriers that I'm often come across and that I hear often is that it increases the levels of stress for the staff and levels of anxiety as well. That feeling of being watched is there and is real. And hopefully today's session starts you thinking about it slightly differently. We should be accountable for the practice that we do, but it's the way we think about they're watching us changes the way we think about having family there. There's always a fear of litigation, and often that's the prime reason. People think, I'm going to be sued if they see what we do in the resuscitation room. They wouldn't want to see that, and then they will sue us. From all the literature that I've read, the fear of litigation is real. However, it is often not the case, and having family there, they're less likely to actually have an understanding of what happened in the resuscitation room. And very, very few, and again, globally, there are different cases across the world. But from what I can see, the litigation is very, very uncommon. The traumatic element of it, we often feel we're protecting the family. You wouldn't want to see that. Now, let's be honest, we can Netflix and Stan and Google and just look up on the internet lots of different and horrendous resuscitations and graphic images. I will say this to you, often the family's imagination of what's happening in that resus room is 100% worse than what actually happens. And if you've worked in resuscitation for many years, you know that it actually is quite a calm, and people speak very calmly and professionally when it happens. And so it's not that big dramatized activity and frenzy activity that we often see in dramatization on television shows. So often we think we're protecting, but in fact, their imaginations are 100% worse. There's always a fear that the family will interfere with the resuscitation. And often when I've done presentations, people will often talk about different cultural groups and ethnic background people that might respond differently to the death and dying process. And I think we've got to actually sit back and think, well, how comfortable am I with their emotions? Do I expect them to be upset? Yes. They may cry. Yes, actually, I expect that. So then why am I uncomfortable? However, in most of the cases, we find very little interference with family members. And if managed, if supported in this environment, then that won't occur. And if it does occur, if they do become in the way or interfering or loud, and it's obstructing the resuscitation effort, then that's where they're supported to actually leave for a point of time and then perhaps come in a bit later. There's also that the staff will become distracted by the family, that having them there, will we go longer? Will we do things differently? We're more conscious of our actions. So therefore we're not performing to our best. Well, I would say that it becomes, the more that we practice this, the more that we implement this, it becomes common and it becomes just part of our normal practice. The enablers to making this happen, and really there's a triangulation of things that need to occur for it to be absolutely embedded in your practice, in your workplace. It's essential that we do education and training. Now think back to the last time that you did advanced life support or CPR training. How much of that was designated, or was there any designated time that talked about having family present during the resuscitation? We often actually learn individual skills of advanced life support or cardiopulmonary resuscitation. We isolate the skills out. You might learn, well, how do we do chest compressions effectively, or how do we manage the airway effectively? But we should be learning that as a team. We should be practicing it as a team on the mannequins. And part of that training should include, well, who's looking after the family? And if we do that and embed it into the education and training, then it becomes just one of those other roles that we should have. There is a real importance across the board of actually a designated family liaison or care coordinator person that is responsible for the family members. Now, I'm going to test that a little bit across very metropolitan, large tertiary centres in comparison to rural, remote or regional centres, because there is a difference about the number of staff availability and about the skill mix of that particular role. It doesn't necessarily have to be a nurse, a doctor. In a lot of different hospitals, they've actually introduced a support person, family liaison or care coordinator that has a physio or OT, social work or even chaplaincy background, has a designated role and a position in the resuscitation area to support the family through the time. But there also needs to be evidence of a formal policy on family presence. And that's really important. If your workplace doesn't, then it's missing an important element. We need to be able to back up that if one of the senior doctors or a team leader says, get them out of here, you've got a policy to back up. Well, actually, our policy at this venue is that we have them in. So, you're backing yourself up there. One of the things that have come out of some of the research that I've been doing is there's a sort of a new element to resuscitations around the use or family members and visitors using video technology to actually record what's happening. It might be an invasive procedure or just in the hospital itself, or a part of the resuscitation. And hospitals and healthcare settings need to have formal policy around clinicians' ability to actually stop that recording, because that's a whole different ballgame. And I think more conversation needs to occur around the use of people being able to video. Now, in the days gone past, it was very obvious when someone was videotaping us because it was a video recorder. But with the technology growing over the years, there's no way I'd know that I was being recorded from somebody's, their watch, a small camera on their, camera on their phone. The technology's grown. So we need to anticipate that technology and respond to it with our formal policies as well. I just want you to very quickly think about all the different roles in the resuscitation room. Like, how many different people are in there? Like, what are the roles that they have, the responsibilities they have? Think about your workplace and think between those big tertiary centres in big cities compared to small country or townships, rural and remote community hospitals or health settings that have a very little number of staff, and how those roles still need to be filled. So have a little go at writing down all the different roles as I'm talking about this. So for example, one role might be the person who scribes or documents. What are the other roles? There's lots and lots. And often they're a mixture of medical and nursing roles, and often even nursing coordinators or hospital coordinators, administrators, administrative staff that assist with the resus. So there's lots of roles here. So some common terminology that is used throughout the literature and across health settings is we always have an airway nurse, but we'd also have an airway doctor, procedure nurse, procedure doctor, often two procedure doctors. You'll have one or two people that will be right on the medication, so drawing up the drugs on the drug trolley and a part of that. You hope that one person is responsible for the defibrillation and doing that. There's somebody doing chest compressions. So who's actually doing CPR? We've got somebody documenting. Now, the scribe's an interesting one because traditionally the scribe was the junior nurse, junior staff member that would be documenting. There's been a lot of body of work to actually suggest that the scribe should be the most important or the most senior person, because in order to actually record all the information that you need to ask prompt questions to get the information, did we just intubate? What size endotracheal tube was put in? How many centimeters to the lips? How many centimeters or how many centimeters of air was actually put into the cuff? All those, what are the pupils doing? Can somebody take a blood pressure? All those prompting things to understand all the complexities of a resuscitation kind of needs to be a senior person. So have a think about, who do we normally get? Do we just get the junior person to do the scribe? We often have a nursing coordinator that hovers around the background. It might be the person, the shift in charge person that looks at sort of the logistics, that all these people and staff are now in the resuscitation. Well, who's looking after the rest of the staff, and how do I coordinate the rest of the hospital? And I've whacked in that family liaison person, because is it a designated role or does it just fall under one of the other roles within here? There's often a team leader, and in a lot of resuscitations, we have a nursing team leader as well as a medical team leader as well. So, and you can see there's multiple roles, but do we always have that many people in a resus? Predominantly, there are 6 main roles: team leader, airway nurse, airway doctor, procedure nurse, procedure doctor, and someone to scribe. And often we interchange all the things that we've got to do. And in smaller venues, they even run with less, which means that one person, say the airway nurse, may have multiple things that they're doing simultaneously. Yes, they're in charge of the airway, but they might be checking some drugs with the procedure nurse to double check. They may be the person that is able to talk to the family at the same time. So multiple roles. It's integrating how that all works at the same time that's the important bit. So the family liaison or care coordinator role really is that person to liaise with the family members. They're explaining what the procedures and what they're seeing. They're talking about expected time frames and timelines, especially if you need to transport them to a bigger or a specialised tertiary centre, and how that will happen, or even just moving them to, say, an intensive care unit. They arrange support. They look whether or not they need social work or chaplaincy, and they usually are the person that has excellent communication skills and good interpersonal. We need somebody that's able to bring that medical jargon down into usable language and layman's terms so that people understand. And they understand the nature of the arrest situation and can explain the healthcare roles, responsibilities, and patient's conditions. So that's a lot for this person to do. And hopefully the ER drip is just one way for them to kind of remember all the different elements of the things that they need to talk to family about. A couple of quotes here of different health professionals when they're talking about family presence. So family presence during resuscitation is very personal. No one really knows what that they would do until put into that situation. And I believe families should be given the option, supported in their choice, and be able to change their minds during the resus. There's some really good key words in there. It should be given option, supported in their choice, and be able to change their minds. I'm advocating for family presence, but I'm also advocating for the choice and the support of it. Giving and actually asking the question, would you like to be present? Would you like to come in? I will stand with you and explain things to you. If you don't want to, that's fine. But and if you change your mind, you can come back and I can take you in later. It's about providing them with the option. As healthcare providers, we need to care for our patients holistically, and that includes the family. So it's all about that choice. It needs to be supported, and we need to have consistency of practice. By consistency of practice across your organisation, then you'll actually start to really make a difference. So a nurse commented on how they didn't really know how to communicate with family, what to explain and how much detail to give. That's always a tricky one. What support services to offer, because it differs between each patient, and when to bring them into the resuscitation. Now, when to bring them in is a really interesting one. If you think to a pediatric resuscitation, the mother or the father is often travels in on with the ambulance, in the ambulance with their child, and comes straight in, follows the child in to the emergency department, for example, is often there. But in an adult coming in by ambulance, they're often told, we're taking the patient and, you need to come to the hospital. This is where we're going. So they get in the car and they come later. So then they come through the front door. They've come through to triage. They've had to ask where their husband and their wife is, or their family member. And then we hear that they're here, and then we have to go out to get them to bring in. And it's really different about that transition about when to bring them in. So often with pediatrics, they're already with the child, but with adults, they're often in the waiting room or on their way. And how best to explain stuff like, or all things to do with procedures, what is occurring and how much to disclose as the resuscitation gets worse. We're very reluctant, and I think our language is very important. We're quite reluctant to say they may die. We don't know, but there is a possibility that they might die. And we've got to be really careful about the language you use. There's a lot of different terms that we use that really gloss over the reality. Yes, they're unwell. They may pass. They're passing. It's that kind of language that really leaves, what does that mean? They're passing where? They're transitioning where? They're transitioning to the ward. Sometimes actually using the very language that is important to really hit home about the seriousness of the resuscitation and the patient's condition. So ER DRIP, what does it stand for? So the E is around explaining is emergency personnel. So first, introduce yourself, what your role is, who you are, and then before you take them in, or even if you've got them in, say it's a pediatric resuscitation, or they're in the resus or in the room when it happens, introduce yourself and then say who everybody is and what their role is in the resuscitation. The reassurance here is to remind us that, to tell them that everything possible is being done. And often to remember back to the fact that many family members have commenced CPR in the home environment and then called an ambulance. They've often been very instrumental in that, seeing the patient collapse and doing CPR themselves. Often they just need reassurance. You did the right thing getting them here. You did the right thing calling the ambulance. You've done all you can. Now we need to do what we need to do. So that's that reassurance. D is diagnosis. It's that reminder that often the family have seen the collapse and they know the patient's backstory or back medical history. They often have a bit of a clue as to what happened. If it's a trauma, they'll definitely know, but they also might know, actually, this is similar to when they had, or when they've had angina, or when they've had chest pain before. So, I'm kind of guessing that they've had a heart attack. So it's understanding what's wrong with the patient. So often asking, what's your understanding? What happened? What do you think's wrong with the patient? I'm not saying that we're going to really, in that instant be able to diagnose, because let's face it, it might be something that we might not know is the cause of the resus and subsequent death until post-mortem. Sometimes it's a subarachnoid or an aneurysm that's popped, and so we don't know what's happened until later, but we've definitely got some ideas. And so it's really important for them to have a bit of an idea and use that layman's term. So not a myocardial infarction, but we're perhaps thinking that it might be a heart attack at this stage. Regular updates reminds me to go back in and out and to say, I will come out, if you're going into, say, a family room, or you're coming out to the waiting room, I will come and update you when I hear the results of the CT or the results of the blood tests. What we've got to avoid in particular is, I'll be back in 5 minutes. I think as health professionals, the worst thing that we can do is say back in 5 minutes, because what's that family going to do? They are going to time you. And if you're not back in 5 minutes. So it's really important that you're going to get rid of that language and say, I will come and give you regular updates. And if the condition changes, we'll let you know what's happening. And the interventions, it's really important to describe all of the lines and the things happening, the machine that goes ping, any infusions that they have, the cardiac monitor, what's those waveforms that are happening up there. So really follow the lines in and out of the patient and explain them in layman's terms. There's nothing worse than families sitting there listening to the heartbeat, the monitor going beep, beep, beep. They're very fixated. If an alarm goes off, that's the one thing they think something is deteriorating. So you need to be really conscious of that and explain what the machines are that are around the patients as well. And the prognosis, here's where we actually need to tell them what's going to happen next. Now, whether or not it's as serious as we actually are concerned that they may die, we want to emphasize the seriousness of their condition at the moment. Or it might be that they need to be airlifted or transported to a larger tertiary centre. And that you need the family to have time to digest that, because they're often a long way from home, and being able to sort of follow the patient along is the tricky nature of it. So it's a really important thing. So I've gone through ER drip. All right, your turn. Here we go. I've gone through it. I know you know it. With your pen, or even in your mind, I want you to go through ER drip and tell me what each letter stands for. I wonder how you went. Let's go. Did you get E is for emergency personnel? Because if the one thing I want you to come out of today is to know this so that you can remember the acronym. So emergency personnel. R is for reassurance. D, diagnosis. R, regular updates. I for interventions. and P for prognosis. So well done if you got them all, and if you didn't, we might even have another test at the end of the session. So I want to talk a little bit about the impact that we've seen globally with the COVID pandemic around this topic. There's been lots of changes, and let's be honest, it's made it really difficult. Having family present during resuscitation has been endorsed across Western countries, in particular from America, UK, Canada, Australia, New Zealand, across globally since the year 2000. It is present in all of our resuscitation guidelines as a recommendation. So since the year 2000, we're now in 22. Back in 2019, before the global pandemic really hit, there was still inconsistency of practice with having family present, depending on the ward, depending on who's on the shift, depending on the location or the geographical location or where you are in the world. There wasn't consistent practice. And with the pandemic, we've really closed the doors. We've really shut down this practice, and we had to. And I understand that. But it's time to sort of rethink about this. But I do want to acknowledge how hard it's been to actually be able to have this practice. And I do want to reflect on some of the voices of health professionals during this time as to how hard it's been not to be able to practice this. There's been a lot of stories of people delaying coming to hospital because of COVID and being socially, restricted to get out to actually come to hospital, but also not wanting to go to hospital until it was really necessary to do that. That delay often is delay to treatment. I was talking to a nurse who told me a story around that the wife had chest pain. They sat at home until it became unbearable and nothing was working. So he put her in the car because he didn't want to call an ambulance, put her in the car, came to the front door of the hospital, wasn't allowed into the hospital or the emergency department because it was barricaded, and there was a sort of a triage area and treatment area outside under tents. He put his wife in a wheelchair and got her to the tent or the triaging area and said goodbye to her. And in she went. Now she was conscious, she was awake, she had some niggly chest pain as he left, and he went home. She made it into the emergency department where she went into full cardiac arrest, and she died very soon after actually making it into the emergency department. And for nurses and doctors working in this area, that's really difficult, having to ring and then say, I'm really sorry, but they died. We resuscitated, we tried. And so there's a real disconnect through the pandemic of family being able to come into even the emergency department and into the wards. And that's really altered the way we practice. Add in that the issues around COVID condition itself and respiratory conditions and the transmission of COVID. So actually going to that point where we're considering intubating, there's a real delay or a real conversation had amongst practitioners before we actually get to that point. Is this necessary for this patient? Do we really need to intubate? Because that adds another layer of care that needs to be provided, but also danger as practitioners around the virus becoming airborne and us contracting it. And then add in PPE, so add in personal protective equipment, and the true nature of having to wear that and then do the act of resuscitation has added intense layers of complexity to this topic. So I'm acknowledging that changes have occurred, and I'm definitely, for many of you, you may still be in states where your hospital has not opened up to visitors or is still restricting visitors and still restricting the practice. Today's conversation is really just about planting the seed, even if it's a small little seed in your mind about the importance of family being connected with a loved one during resuscitation and having that moment to say goodbye. And how in this new world and the new changes and a new way of practicing can this now be brought back into practice in whatever form or in some degree. Then even the sheer nature of a resuscitation, the look of it looks different. Here we are in full PPE now. The videos that I'm going to show you today are not in PPE, and they were made just prior to COVID. And so I do want you to reflect on the fact that what we're trying to teach is still there, but we recognise that in fact that PPE has become part of the way we practice, and especially during resuscitation. The other thing I just wanted to mention quickly was around, there's a whole lot of new algorithms and things designed during the pandemic that really changes the way we resus and when a patient collapses. And here, this one, which was written by the American Medical Association, and actually uses the word pandemic to remind ourselves that in fact PPE and protecting ourselves is first on the list when somebody needs resuscitation. And then you're going to alert the resus team. You're not going to do the breathing, and that's normal practice, going straight to defibrillation, and then remove non-essential staff, so minimal. So when we look back to that all those roles and responsibilities and the team that we had, we're minimizing the number of people that are actually a part of a resus. So even training now needs to change around, well, how can we manage this with only, say, 3 staff or 2 staff? How do you minimize that? Then, because you're minimizing the exposure. So lots of changes to the way we practice. I just want to talk very quickly about the difference between adult and pediatric resus, and I breached on it just briefly before. Whenever I do this, and traditionally, I always say to people, why is it that we're comfortable having parents in with a pediatric resuscitation, but in an adult resuscitation, the first thing that we think of is to remove family from the room? Which one's more stressful for us as practitioners? Which one is the higher anxiety levels? Which one takes more brain cells to function in? And I would say it's the pediatric resuscitation. The sheer changes in calculations, in the medication that we've got to give, the differences in the size of the equipment, depending on the size of the child, and the anxiety around the fact that a child shouldn't be in a resus state heightens our anxieties. And yet we seem to be quite comfortable, and that's become normal practice to have parents in the room. So why then in adult resuscitation? Now, in adult resuscitation, the algorithms, there's quite a generic drug amount that we're giving for adrenaline or epinephrine and all of them. So why is it different? And really, there's a difference in the way we kind of deal with adults compared to pediatric resuscitations. I want to make a point. When it's an adult resus, the family's focus is on you or the machine. Their eyes are drawn to you. They're still conscious of the family member, but they are really conscious of what you're doing. Now, for me, this point here really changed the way I thought about resuscitation. I anticipated that I would be the focus for them, or the machines would be the focus. Why is that? It's because the family or the patient was an able-bodied, self-caring adult, and therefore I'm here to support them, but that they were able-bodied before. So there's a slightly different relationship with a family member of an adult patient. In comparison, a parent, their focus is on the child. They're assisting the child to get through whatever procedure is occurring. They're much more in tune with the child and what they're experiencing, and quite oblivious to what's happening on the bigger picture, the global. So just by understanding that, it changes your focus during the resuscitation. It also makes you understand why in an adult resus, the family members are asking lots of questions, and what are you doing there, and how much are you giving, and what's happening next. But in a pediatric one, they're much more focused on the child themselves. So I'm just going to stop sharing that, and we're going to actually put on a video and have a look. Close that down and show. There you'll see my inner workings of my computer and how I function. And here it comes.
All right, thanks very much. We'll see you shortly, guys. Hey, Aaron, just got a call from ambulance. 80-year-old female, collapsed at home this morning, query stroke. Altered conscious state, GCS of 10, complaint of a right-sided hemiplegia. Estimated time of arrival, about 10 minutes.
Okay.
Hilda, we're just going to take this mask off and we're going to get you to the hospital bed, okay? All right, guys, you happy to get her across and then hand over?
Yeah, sure.
That's good.
All right. It's all right, Hilda, you're doing very well. We'll just go over on the sheet.
Yep, no worries.
Hilda, we're going to roll you to your right-hand side, okay? You stay nice and still for us. Everyone ready?
Yep.
1, 2, 3.
Yep.
Back, 2, 3. Hilda, you're going to slide over to the hospital bed now, all right? Don't grab at anything. Just keep nice and still. Everyone ready?
Yep.
1, 2, 3.
Okay. I'll come and get handover.
Excellent.
Yep.
We'll just put this side rail up. Alright, so this is 80-year-old Hilda. Hilda was found post an unwitnessed collapse at her home this morning by her son. She presents with a right-sided weakness, slurred speech, altered conscious state, GCS of 10. She's got no medical history, no medications, no allergies.
Okay. No worries. And son, family?
Son's on his way in. He was
Okay.
right behind us.
Sure. No worries. Okay. Thank you. Okay, I've got a gown here for you. Hilda, we're just going to get you into a gown now, okay? Oh, Amy.
Hi.
Hilda's an 80-year-old lady who's come from home
Yep.
following an unwitnessed collapse.
Yep.
We think she's had a stroke, so she's
Okay.
had some, the AMBOs have noticed that she's had some right-sided hemiplegia to her arm and her leg.
Yep.
And her GCS is 10 at the moment, so
Okay.
she's quite unwell. We're just getting her changed and we'll do a set of obs.
Sure, okay.
And we'll go from there.
And there's some family coming?
Yeah, I believe her son is on her way.
Okay.
On his way, sorry.
Good.
Yep. Hilda, I'm just going to pop a blood pressure cuff on your arm, just so we can see how your blood pressure is going. This is going to have a look at your oxygen levels in your body, okay? Just a peg there.
Just removing your necklace, Hilda.
Hi Hilda, I'm Amy. I'm one of the doctors here. How are you going there? Can you talk to us at all? Okay. So you've had a bit of a collapse at home.
Hi, guys. Just letting you know that Hilda's son's arrived. He's in the relatives room. Admission paperwork's done. Whenever you're ready.
Thanks.
Hi, my name's Joanne. I'm one of the emergency nurses. I'm one of the ones looking after Hilda, who's just been brought in by ambulance. Are you related to Hilda at all?
Yeah, I'm a son. Is she all right?
Right. Well, I'll just let you know that we've just brought her in from the ambulance and we've just transferred her over to one of our emergency trolleys. There's lots of nurses and doctors in there at the moment examining her, and we're just getting her settled into bed. We need to let you know that we really don't know what's happening with her at the moment, but it looks like, it appears that she might have had a stroke. You might have noticed that she's a bit weak on that right side.
Yeah, but when can I see her?
You'll be able to see her soon, but what we need to do first is we need to go and have a CT scan, and once we've had that CT scan of her brain, we'll know much more about what's happening and be able to let you know. So as soon as that scan has been done, I'll come and let you know what's happening. Okay? All right.
Okay, thanks.
So as you can see with that scenario, he's left in the waiting room and he just sits there waiting. And what I'm going to do now is I'm going to change that scenario and go back to where we're going to pick up where I come in to actually talk to him using that ER drip algorithm to actually talk to him and then see the difference of how we respond and bring him into the emergency department.
Hi Hilda, I'm Amy. I'm one of the doctors here. How are you going there? Can you talk to us at all? Okay. So you've had a bit of a collapse at home.
Hi guys, just letting you know that Hilda's son's arrived. He's in the relatives room. Admission paperwork's done. Whenever you're ready.
Thanks, Tom.
Hi, my name's Joanne. I'm one of the emergency nurses.
Hi.
And I'm just looking after Hilda in the resus bay. Are you related to Hilda at all?
Yeah, I'm a son, Wayne.
Oh, great. Wayne, can you tell me what happened today?
Oh, Mum lives in a flat behind my place, and she asked me to check on her before going to work this morning, which is very unusual, and I never do that. So I did, and went into her apartment, and I found her collapsed on the floor. Didn't know what had happened. She didn't recognise me. She couldn't speak. So I rang the ambulance, and yeah, they looked after her, got her here, and
Yeah. Wayne, you did all the right things. You recognised that she was very unwell and you called an ambulance. So you did all the right things. This is the best place for her.
Yeah.
Just letting you know that she has arrived, and we've just transferred her over from the ambulance trolley over to our emergency trolley, and she's in the resuscitation room at the moment.
Is she okay?
I wouldn't say she's okay, Wayne. You know that she's very unwell at the moment. We're not really sure what's going on at the moment, but you did notice that she might have had that right-sided weakness. So it looks like she might have had a stroke. But the only way to really know for sure is we need a CT of her brain, which is a scan of her head, and we'll be able to see whether or not she's had that bleed. So we'll know much more information once we've had that scan. We've ordered it, but and she'll go for that scan soon. So as soon as I know results from the scan, I'll let you know. Okay. So just letting you know that there's it's very busy in there at the moment. There's lots of emergency nurses, and the emergency doctor is also with her, and they're examining her. They're hooking her up to the cardiac monitor, so she's got lots of leads on, which is just taking her heart rhythm and her pulse. She's also got a face mask on, just sitting on her face to give her a bit more oxygen. And she's responding to us a little bit, but not much, and we can see that deficit. Okay, so we'll know what's happening more when we've got that CT scan. And we'll let you know as soon as we've got any results. All right. So I just let you know that at any stage you can come with me into the resus room, and I can take you through. But if you don't feel comfortable, either now or later, this room's available for you, so you can always come back here. But I'm going to stay with you, and I'll answer any questions you might have about your mother. Okay. All right. Would you like to come in and see her?
Yeah, I really would.
Okay. So if you come with me now, then.
Yeah.
Okay.
Just going to get you to give my hands a bit of.
So it's interesting when you just change a slight part of the story and how you manage the patient and the family, that you can make a difference. And it's right at that point where, especially with an adult resus, where you go out and to explain what's happening, and you just change using that ER drip to actually explain what's happening and give choice, and then to be able to provide an opportunity for them to come in. I'm going to stop it there. I can't believe the time's gone so fast, and I know that perhaps you've maybe got some questions or comments, but hopefully that's re-sparked that enthusiasm that you have, or that interest, or just even getting you thinking about the importance of having family there and providing opportunities for family members to actually say goodbye during a resuscitation.
I want to thank you, Joanne, for sharing all of this great information. We do only have about a minute or two for any questions, so we'll wait to see if any come in. If people want to reach out to you afterwards, what would be a good way for participants to connect with you?
I think just via email is great. Very happy to talk. I think this is a topic that is close to all of our hearts across the world. So I'm more than happy. And I think, Megan, you're going to make the slides available, which has a list of publications that I've been involved in over a number of years now. So the work is out there, and I'm happy to share and happy to have other conversations.
That's wonderful. And seeing all the chats and the comment, everyone has so much great to great things to say, and they're wondering if we could share your email address in the chat feature. Is that okay with you?
It is indeed. Typing it now.
Awesome. And this will foster great collaboration globally for people to have these conversations and to really, be mindful of this moving forward. So we want to thank you for that. I want to thank you so much for sharing all of this great information. We are so thankful that you took time to share with our audience today, and we definitely look forward to hearing more from you in the future. We hope that you enjoyed this webinar. As a reminder, 1 week from today, you will receive an email with the link so you can see the recording, the slides, which would also include Joanne's references, and information on how you can obtain your Nursing Continuing Professional Development Certificate. Be sure to check out Sigma's other upcoming webinars and resources to support you and your colleagues at sigmanursing.org. Thank you so much for joining us and have a wonderful day.
Thank you.